Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Hello dear students. Welcome in our surgery lecture number 21, that is the diseases of the small intestine. In this lecture series, we will see the tuberculosis of the intestine, hyperplastic Ileo-caecal tuberculosis, ulcerative tuberculosis and the Crohn's disease. First start with the tuberculosis of the intestine. Tuberculosis of small intestine occurs in two forms, that is the primary infection is usually due to the bovine strain of Mycobacterium tuberculosis and results from ingesting the infected milk. In India, the human strain may also cause such primary tuberculosis. This produces hyperplastic tuberculosis and occurs most commonly in ileocaecal region, although solitary or multiple lesions of the lower ileum may be present. The more common form is ulcerative tuberculosis, is secondary to pulmonary tuberculosis and arises as a result of swallowing tubercle bacilli. Students, you can see a good image of the tuberculosis of intestine. Next image is also the tuberculosis of intestine. Good image. This is the ulcerative tuberculosis of the intestine, also a good image. Now the next point is hyperplastic Ileo-caecal tuberculosis. Now pathology, it occurs in a patient who has already developed resistance against the Mycobacterium tuberculosis due to the ingestion of Mycobacterium tuberculosis bovis. Terminal 2 inches of ileum and the caecum are usually affected. Intestinal wall becomes thickened. Thickening due to the tubercular granulation tissues and edema causes narrowing of the affected segments. Now the clinical features of hyperplastic Ileo-caecal tuberculosis are attack of abdominal pain and undue to sub-acute intestinal obstruction may be associated with intermittent diarrhea. Second clinical features of hyperplastic Ileo-caecal tuberculosis are features of blind loop syndrome may develop due to stasis, distention and chronic infection in the segment of ileum proximal to obstruction. Anemia due to vitamin B12 deficiency, loss of weight and steatorrhea are the features of the blind loop syndrome. Third clinical features is a mass in right iliac fossa. Here is a good picture of hyperplastic Ileo-caecal tuberculosis. You can watch on your screen. This is the another image of CT abdomen thickening at the IC junction. You can clearly see on the CT scan. This is the animated picture showing the Ileo-caecal tuberculosis hyperplastic IC junction. Incompetent ileocaecal wall is there. Stricture of ileum is also seen. Ulcerative ascending colon is clearly seen in this image. Now the special investigation should be performed in the hyperplastic Ileo-caecal tuberculosis are no other investigation is very suggestive of this condition, but barium meal X-ray is very indicative. Barium meal radiography will reveal the persistent narrowing of the affected segment, that is the terminal ileum and caecum. Caecum is pulled up and may become subhepatic. Due to pulled up, the ileocaecal angle is widened. Normally the angle is 90 degree, may increase up to 180 degree. Stool exam may reveal blood and mucus occasionally. ESR is usually not high. Chest X-ray is negative in most of the cases. Treatment: if no intestinal obstruction, then antitubercular chemotherapy with sanitary regimen. If obstruction, then surgical intervention, right hemicolectomy should be performed with removal of diseased segment. In acute obstruction and patient's general condition is poor, then defunctioning ileocolostomy to bypass the disease segment should be performed. Now the next point is the ulcerative tuberculosis. Pathology, it is usually secondary to pulmonary tuberculosis and results from swallowing of tubercle bacilli. Terminal ileum is mostly affected, multiple ulcers is there, long axis of which transversally, the ulcers are with long axis which are transverse, typhoid ulcers are longitudinally placed. Due to this fibrosis and transverse deposition, single or multiple strictures of the ileum are not infrequent. Clinical features are this type of tuberculosis start with diarrhea at the main symptom. As the main symptom, stool contains pus and have a bad odor with occult blood bleeding from the ulcer. The patient gradually loses weight. These patients are often known as the tubercular patients. Dear student, this is the image you are seeing on your screen is the ulcerative tuberculosis. This is the another image of ulcerative tuberculosis. This is the picture of small intestines of jejunum and ileum. Ulcerative cirrhosis is there, ulcerative tuberculosis of the intestine. Now the image showing the intestinal tuberculosis, ulcerative type and hyperplastic type. There are two types of intestinal tuberculosis, ulcerative and hyperplastic. Ulcerative formation of mucosal ulcers, clinical features are bleeding, perforation, fistulation and stricture. Where the hyperplastic type of intestinal tuberculosis, extensive inflammatory changes is there, obstruction and mass is present there. Now the investigations of ulcerative tuberculosis are stool exam, routine blood exam should perform, increase where the increased lymphocytes, increased ESR, chest X-ray reveals pulmonary tuberculosis, barium meal exam fails to detect any abnormality in the lower ileum. Now the treatment for the ulcerative colitis, first conservative treatment, anti-tubercular chemotherapy and sanitary regimen should be started. In stricture, required bypass the stricture segment, and if there is a perforation, immediate surgical intervention is required. Now the next point is Crohn's disease. In 1932, Crohn described this disease as a terminal ileitis. Gradually it was recognized that the disease, though most frequent in the terminal ileum, may involve any portion of the GI tract from mouth to anus. There are two commonest sites of this disease is terminal ileum and the anal canal. Now the pathogenesis and etiology are unknown. May be due to the Crohn's disease, may be due to the trauma, lymphatic obstruction, absorption of toxic substances from food, inherited metabolic defects, predisposing genetic defects such as the Turner syndrome, and next point is imbalance between sympathetic and parasympathetic nerve activity, etc. Dear students, you can see the good pictures of Crohn's disease and colitis ulcerosa on your screen. That is, the sites of the Crohn's disease are clearly seen in red color, and in the second picture the colitis ulcerosa is continue with the transverse colon to the up to the anus. Very good picture differentiation showing the Crohn's disease between the Crohn's disease and the colitis ulcerosa. Next image showing image of the Crohn's disease where the normal intestine is showing and the Crohn's disease intestine is also showing. There is a stricture in the intestine, fibrosis of the muscular layer of the intestine. You can clearly see the lumen is narrowing. Here is a good picture of Crohn's disease of the intestine. This is the another picture of Crohn's disease of intestine. Now the pathology of Crohn's disease is 60% contributes ileum and 30% in large intestine. Chances of 30% in large intestine. Disease segments are dull purple, red thickened 2 to 3 times normal diameter and covered with strands and patches of thick greyish white exudates. All layers of the bowel wall are involved in transmural inflammatory process. Lumen is narrow and fibrosis, edema and cellular infiltration. Involved segments are often adherent to adjacent loops or other viscera. Due to this intense serosal reaction, affected loops adhere to the neighboring structures. Serpiginous ulcers may develop. Long snail tract ulcers may be produced from coalescence of the previous ulcers. These ulcers penetrate deep into the muscle layers of the gut, distinguishing from the other inflammatory diseases of the bowel such as ulcerative colitis or ischemic colitis. Transmural inflammatory reactions in gut, thickening of the wall, fibrotic stenosis, complications like perforation, abscess and fistula. The anal lesions consist of fissure, fistulas, perianal abscesses or spreading superficial ulcerations. Now the clinical features of the Crohn's disease are acute ileitis. 10% of patients are young. The onset is acute. Right lower quadrant pain, low grade fever, leukocytosis, often nausea and vomiting, occasionally diarrhea. It mimics acute appendicitis. All these symptoms are common with the acute appendicitis, so these symptoms is mimicked with this condition. Now the chronic ileitis, onset is insidious, the course is protracted and slowly progressive, pain due to partial obstruction of the lumen and increase in mortality proximal to the site of obstruction, fever, presents only 1/3 of their patients, malnutrition, weight loss, anemia, hyperproteinemia, vitamin and minerals. Anal lesions may herald the onset of the disease by many years. So there is a development of fissure in ano, fistula in ano. In such condition, these are the herald of the Crohn's disease or chronic ileitis. The most common lesions is anal fissure. It is a broad, shallow ulcer rather than a crack. In nutshell, chronic renal ileitis manifests in 3 stages. First stage is abdominal pain, diarrhea, fever, anemia and loss of weight. Second stage, Symptoms of acute and chronic intestinal obstruction. Third stage is formation of adhesions, abscess and fistulas, may be internal, pelvic colon and enterocolic or urinary bladder, that is the enterovesical. External fistula develops in right iliac fossa. Investigations. There is no specific lab test for Crohn's disease. Diagnosis rests on clinical evaluation and supported by endoscopy, endoscopic biopsy and radiology. Radiology. Barium study of bowel is vital to the diagnosis of Crohn's disease. Barium enema is used to diagnose this condition. Radiologically can be divided into two stages, A in the non-stenosing stage and B in the stenosing stage. In the non-stenosing stage, ulcers combined with submucosal edema produce a coarse nodularity and cobblestone pattern which become the obvious filling defect due to the edema. In stenosing stage, affected bowel looks like a rigid tube. There is no cobblestone pattern. There is a gross irregular narrowing of the terminal ileum. Due to acute transmural and inflammation and edema with spasm, end result of fibrosis leading to stricture formation of the intestine. Next investigation is endoscopy, that is the colonoscopy should be performed. Direct visualization of the pathology, one can find inflamed mucosa, irregular and ulcerated with mucopurulent exudates. Next investigation is biopsy. Rectal biopsy is frequently of wall is establishing in the findings in the diagnosis. Next investigation is the CT scan for intra-abdominal abscesses or to exclude other complications. So, CT scan should be performed, should be done. Next investigation is MRI, useful in assessing perianal disease. Treatment. Unfortunate Crohn's disease is hardly curative either by medical or surgical treatment. Now, the medical treatment, first general treatment, bed rest, high protein diet with vitamin supplementation. Important is correction of hematological and biochemical deficiencies with appropriate in therapy, that is folate, vitamin B12, etc. should be supplement. Steroid therapy, short term steroid therapy for non-obstructive active small bowel diseases, that is the prednisolone 40 mg orally daily along with 5-ASA, that is the 5-amino-salicylic acid compounds, sulfasalazine, salazopyrin. Both prednisolone and sulfasalazine are effective when the disease involves the colon as well as the ileum. Azathioprine, this immune suppressive drug is in the experimental stage. Antibiotics particularly helpful in acute stage. Gentamicin and metronidazole. In short, till today, no drug has been found to work efficiently in this disease. Now, the surgical treatment in Crohn's disease at last ultimately needs surgical treatment. Indication: failure of medical treatment to control this disease, development of complications, obstruction, perforations, formation of abscess and internal fistulas. Choice of operations in Crohn's diseases: resection with immediate and anastomosis. For ileocaecal Crohn's disease, right hemicolectomy with end to end and end to side ileotransverse anastomosis should be performed. For colonic Crohn's disease, segmental colectomy or total colectomy with ileorectal anastomosis should be performed. For local small bowel involvement, segmental resection is enough. For large segment with multiple strictures, stricturoplasty should be performed. Dear students, here is the end of our surgery lecture number 21, diseases of the small intestine. Thank you.